Hi, everyone, and welcome to a new episode of the 2024 Global P.A.D. Impact Awards brought to you by the Global P.A.D. Association. It is a great privilege to introduce a pioneering leader in cardiology who is our esteemed recipient of the U.S. Interventional Cardiologist of the Year Award for his relentless pursuit of innovative treatment strategies that have significantly advanced P.A.D. care. His commitment to advancing patient care is evident in his adoption of novel treatment approaches that reduce repeated interventions, minimize amputations, enhance patient outcomes, and ultimately improve the quality of life for patients in his area. In addition to his clinical work, this doctor is passionate about advancing P.A.D. research and treatments, as well as educating other healthcare professionals, patients, and policymakers about P.A.D. But at the heart of his practice is an unwavering, deep commitment to patient-centered care. The award recipient is known for his empathetic approach to communicating with patients, ensuring that they feel heard and involved in their treatment decisions. And I know this because I've talked to these patients. His ability to connect with patients on a personal level is a cornerstone of his success. So without further delay, it is with great pleasure that I introduce you to Dr. John George, a leader in the fight against amputations and the recipient of the Interventional Cardiologist of the Year Award for the United States for 2024. Dr. John George, congratulations, and thank you so much for all you do to save life and limb.
Thank you so much, Kim. I appreciate this award. I'm truly honored to receive this and excited to be here with you.
You know, you're an interventional cardiologist. You have so many different things you could be doing right now. Why peripheral artery disease? Why is that your primary focus?
Well, obviously, I got into peripheral vascular interventions as a cardiologist because we started seeing a lot of these patients intersect within the cardiac space. So, as you know, people that present to us with coronary disease also have extensive atherosclerotic burden in other vascular territories, including the neck and the carotid arteries going to the brain, and also the lower extremities going to the legs. The majority of these patients all have the same risk factors. They all have diabetes, hypertension, high cholesterol levels, family history of all of this, sedentary lifestyles. And so you see a combination of these risk factors cause a variety of these symptoms. And so it's hard to be in the cardiovascular space and not see peripheral vascular disease patients. So that's how my entry into this space was. And obviously, when I trained for interventional fellowship, I was fortunately in the subset that was trained in peripheral vascular interventions as well. And since then, what I've realized is that these are the patients that are often ignored and often not treated because there aren't enough operators in this space to be able to revascularize these patients. And as you know, it's an epidemic in this country, and the number of amputations that we do in this country is horrendous. And so we need to get to a point where we're able to revascularize these patients and obviously improve their quality of life.
Yeah, and we're seeing this, the weight of the media that's out there and the weight of the emphasis on amputations being caused by allegedly too many minimally invasive procedures and possibly even too soon. And I say allegedly because there's no actual tangible proof that that's happened. There's data that may allude to it, but there's no tangible data. However, there is tangible data that shows the majority of the amputations that are occurring are without doctors following Society for Vascular Surgery and American Heart Association guidelines that state an attempt should be made to restore inline flow prior to any amputation. And 90% of those that are occurring are being performed without even a vascular evaluation at all in the year prior. And those are hard numbers. You know, it's interesting that as part of that, there are doctors that say, well, I at least tried to restore inline flow. But just like a patient today, the doctor only tried to restore inline flow to the knee. And he told the patient, well, your vessels below the knee are occluded and it's not possible to treat them because they're too small to treat. Didn't even try poking in the foot and coming up from below. Just said, nope, amputation. And then they found us and we were able to get them to another doctor that does treat below the knee and will give this patient that extra chance to see if they can save the leg. But how is it that you've been able to be one of those few doctors that says, you know what? No option is not good enough for me. I need to find a way. I need to find an option for these no option patients and make the impossible possible.
Well, Kim, I think you mentioned some great points. I think the biggest issue is the lack of awareness and education. The reality is that the bulk of these patients are not even diagnosed, and if they're not diagnosed, they're not getting any of the care that they need. That's step one. Step two is they are diagnosed, they're seen by a physician within the space, and they are told the things that you mentioned, where there's nothing that can be done and it stops there rather than referring to an operator or a facility where advanced procedures can be done. We're fortunate to live in an era where technology has been amazing, has developed at a very rapid rate, and we are able to do all kinds of complex procedures now with minimally invasive approaches. And some of the things that you mentioned, going alternate access areas, going from the foot, going from even the toes, to be able to revascularize what was deemed unrevascularizable before. And even when those arteries are not accessible, we have other ways of even bypassing arteries percutaneously, so minimally invasively, and getting into the venous side and then coming back into the arterial side to be able to provide flow into areas that did not have flow. So it takes a lot to be in that territory where you say you're unrevascularizable. It all is a matter of perspective and getting to the right place and getting to operators with skill levels to be able to do the advanced procedure. So, I'm fortunate to have been in that space for a while, to be able to see a lot of these referrals for patients that have been deemed unrevascularizable, and we find ways to allow inline blood flow. What we want to try to improve, though, are the outcomes on these patients. And the way you improve outcomes is by early diagnosis and getting to them early before they have tissue loss and gangrene and starting to lose their toes and ulcers. And so the earlier you can get to the patient, the better their outcomes over the long term. But even the advanced disease, the key is to limit the level of amputation. So even if you can live with losing toes as opposed to losing the entire limb, you can do a lot better from an entire cardiovascular state as far as the quality of life for the patient. So we try to limit the impact on the patient from the advanced disease that they have.
It's interesting because we had a doctor that just came on about a week ago that said, I couldn't believe what I actually heard was that there's no point in actually testing a patient that doesn't have symptoms because we can't do anything anyway until they do. And I said, okay, well, that's coming from the plumber's perspective, possibly. Well, no, maybe at that point, for some doctors, if they're just the plumber, there isn't anything you should be doing at that point. But we need these patients to come in at the asymptomatic level because there is so much that can be done to mitigate the risk factors and stall progression of disease. So when you're talking to, let's say, primary care physicians, and your other healthcare professionals in your team, in your facility, what is it that you tell them can be done to help mitigate the risk? We need to get these patients in tested early, diagnosed early, because here's what can be done to mitigate the risk factors and stall progression. What do you tell them to convince them it's worth testing?
Yeah, absolutely. Because I think you hit the nail on the head, Kim. The reality is, again, as I mentioned at the beginning, that this is an intersection of the entire vascular space. So you have coronary disease, you have cerebrovascular disease, and you have peripheral arterial disease. They all intersect. And perhaps PAD may be their initial presentation, but they may have underlying coronary disease. They may have underlying carotid disease. And what you're preventing is not just progression of PAD if they come in first with that diagnosis, but with adequate intervention and treatment with medical therapy, you may be delaying the presentation of coronary disease with a heart attack, or you may be delaying the presentation of carotid disease with a stroke. And so there are implications far beyond the lower extremities in these patients. And so it is really important to think of it as the entire patient. And it's not just about the intervention, but it's about the atherosclerotic burden in that patient and trying to prevent the sequelae of that in any vascular territory. And so that may involve controlling the blood pressure, controlling, their diet, controlling their lifestyle with exercise, controlling their blood pressure and cholesterol. And so it's a combination of all of these things. And at some point, if they're still symptomatic, or if they're symptomatic to the point where they have, target organ damage, or they have, ulceration or gangrene or resting ischemia, limb-threatening ischemia, then they may require obvious early intervention.
And when they do require the interventions, one of the criteria for this award was um, your ability to reduce the number of repeated interventions. The revolving door of treatments is really a big deal, and we've got to reduce those to not only help patients to live a better quality of life, but also to reduce the amount of criticism, right, that's out there for these minimally invasive procedures. What patients have told me about you is that you do a little talking to with them, and you say that there's I do my part. This is my part, and this is your part. It's now your turn. And I think that that might be one of the secrets to your success in reducing these repeated interventions. Can you talk to us about your conversations with these patients to say, hey, this is my part, but now it's up to you?
Yes, absolutely, Kim. So the reality is that, when we see a patient with peripheral vascular disease, it's not something that happened overnight. This is atherosclerotic progression of plaque inside your arteries that has happened over several years, maybe decades. And it's miraculous that you're able to perhaps debride or debulk the plaque that's in there, open up the artery, improve blood flow, and you're back at square one. But if you haven't impacted all the other risk factors that prompted the patient to get there in the first place, this is a revolving door. This patient will keep coming back for the same problem. And so it's a combination of things. We can do a lot on the technical side as far as opening up blockages, but it requires a lot more from lifestyle modification, risk factor modification, exercise, and medications and medication compliance. And so these are all things that we can talk to the patient about, but in the end, they need to understand the importance of it and follow through on it. And so these are things that we re-emphasize every time we see the patient. But that's a conversation that I have right at the beginning, that there's a part that I can do, and there's a part that the patient needs to do. And so I take responsibility for the technical component of what I do, but the patient needs to take responsibility for their lifestyle modification.
Yeah, and I think that's key because the number one thing that our patients say is there's so many doctors that aren't communicating with them, even to the point of walking. They say that the doctors just say, oh, go home and walk, but they don't talk about how you need to walk effectively to grow your collateral vessels, to grow those natural bypasses, the fact that you have to walk through the claudication. Don't just stop. You need to push through the pain, no gain. I mean, I'm being cliche, but it is true when it comes to peripheral artery disease. And so I hear that you do go above and beyond to take the time with the patients. And I think that's why your patients, the ones that have come to us to say, we want him. He is the top guy. He
What's
needs to be
that?
nominated for this award. They said that they really appreciated
I don't
that
know.
about you. But you mentioned it again, we were talking about the repeated interventions, and there are so many doctors that still refuse to this day to even perform a procedure below the knee because it is a revolving door of treatments for the most part, right? And they still rely upon, let's say, 2013 data. I've heard that quoted so many times as a reason why doctors will not treat below the knee. And I'm curious, what data do you use, that help create your philosophy on why you should treat below the knee? And what data are you working to create through your research to improve the patency rates for these patients when you do treat the vessels below the knee?
Yeah, so first, do no harm. So the reality is we don't want to lose the vessels below the knee. And so the reason why there was a lot of resistance and hesitation early on to work below the knee is because the risk is higher because the vessels are smaller. And if you lose them, that's the target flow into that limb. And so you want to make sure that you don't lose that. And so a lack of experience or a lack of confidence will easily dissuade you from working below the knee uh, because it is a high risk, high gain territory. But you have to realize even though the risk goes up, the gain is huge in patients that have limb-threatening ischemia. So the indication matters. If you're doing it just for claudication, you're trying to improve lifestyle, you're trying to improve the quality of life for the patient. There's no reason to go aggressive below the knee because you can most likely impact the symptoms from just the interventions above the knee. Now, if you're talking about limb-threatening ischemia, it's a whole different scenario. If you improve the flow above the knee and you have no flow below the knee, you're not improving the perfusion of that limb, and so you're not improving the target issue, which is the non-healing ulcer or the gangrene or threatening of the threat to the limb. And so for those reasons, you need to be aggressive. And technology, like I said, has improved dramatically, and now we have a lot of options. We're able to do minimally invasive procedures with less threat to that artery. The goal is never to lose the artery, so there is a risk, but the gain is so much greater. And so you're able to do atherectomy, you're able to do drug-coated balloon angioplasty. You're able to do even stenting if we need to below the knee when it's indicated, because in the end, what you're trying to do is improve outcomes in those patients. And it's a moving target because as technology improves and as trial data come out on the outcomes of these novel new procedures, there's going to be more options available for our patients. We now have bioresorbable stents that are available now below the knee. We have drug-coated technology that's available below the knee. We have all kinds of atherectomy devices available below the knee. And we have alternative access options available below the knee. And so I think the options continue to increase as time goes on, as technology advances, and I try to keep myself at the leading edge of that space as new technology comes out.
Yeah, what are you most excited about? I know that there was one. There's a company called Reflow, and I know you visited the facility. I think that that's an exciting new technology that I believe it's already gotten CE mark. They are waiting for commercialization on that for the US, the FDA to come in here. But I would love for you to talk about that technology and why you're excited about that particular technology, especially because it is below the knee. And I think that this technology in particular is going to possibly lead more physicians that have been hesitant to treat below the knee to treat, because a lot of the surgeons, one of their biggest complaints is we don't want to potentially, and because they're so fragile down there, below the knee, they don't want to potentially hurt a potential landing zone, meaning a place where a bypass could potentially reattach and reroute blood flow below the knee. So they just don't want to touch it. They're really afraid. But I think that maybe with this new technology from reflow that I'd love for you to talk about, we might win some additional doctors over.
Yeah, so it's great. It's a spur device, so it's basically a stent that expands in the tibial vessels below the knee to deploy a stent, but you don't leave the stent behind. So you're basically expanding, deploying a stent, and retrieving it to allow excoriation of that plaque within the vessel and also improve the lumen gain within that vessel. And so you have the advantages of putting a stent in without the disadvantages of leaving something permanent behind. And so it preserves all options for the future. So the trial data, the trial just completed, and the data is being evaluated, and hopefully we'll have this technology available for commercial use in the US. But it is exciting. I think technologies like this allow thinking outside of the box and allowing options for patients that may not have these other options otherwise.
And one of the things I noticed with that one is that I think makes a difference, and especially as they go into testing, even in the heart, especially in the heart, is that they expand this metal scaffolding, right? And then they bring up a balloon to further push it, aside. But when they bring the balloon down, I think they bring it up and bring it down several times. But when they bring it down and just let the scaffolding do its job to hold it open, what I like is that the blood flow is actually going through during the treatment, which I was wondering if that actually may make a difference. I know it will for the heart, but could that help make a difference in the patency rate for a patient? Because, and I don't know how to word this, the blood's kind of getting used to going through there, through an open vessel. It's not getting blocked up and becoming turbulent, which could lead to more blood clots.
Yeah,
Am I
so
onto something? You can contradict me if you want, if I'm completely off base.
the idea, no, honestly, when you have prolonged inflation, we know that patency is better when you have prolonged inflation. We know that from the old studies, balloon angioplasty studies that have been done. The problem is recoil. When you do a short inflation and deflate the balloon, the artery tends to recoil and just go back to its original state. That's when stents became popular, because stent is a scaffolding that keeps that artery open and it stays open with the scaffolding in place. The problem with that is you develop restenosis inside stents, and stents can themselves cause issues over time. And that's where drug elution came in, where drug elution prevents the stents from closing off and keeps them open for a longer period of time. But then the length of those stents are limited. So where this comes in from Reflow Medical, the advantage is that you have a stent scaffold that stays in during the most critical time, which is right when the intervention is being done. But before the end of the procedure, that scaffolding comes out. And in that process, during that prolonged process of inflating the balloon and deflating it, and the stent staying in place, the reality is that you have intermittent perfusion of that segment. Now, whether that has a long-term play in why patency is better in that, I don't know yet. I don't think we have
Yeah.
enough data to say that. But the concept and the idea is novel, and it's exciting. It's exciting because you don't have any a threat of collapsing the distal vessels because there is still flow through the period of the intervention.
There, that's what I was trying to say. You said it so perfectly. I'm not a doctor, but So it just was logically playing through my mind because I could see it definitely in the heart where you can't leave a balloon up very long, right? So
Yeah.
definitely in the heart where you can bring it down and still have the scaffolding holding the plaque aside and allowing blood flow to go through, that I think could make a huge difference.
Yep, absolutely. And
So I want to
yeah,
go
go
ahead.
ahead. No, when the
I was,
scaffold goes up, I mean the reality is when the scaffold goes up, it's essentially like a stented vessel, which is wide open, and so that's the exciting part that you completely resume normal blood flow into that artery, but then it doesn't stay for the long term for the consequences.
yep. So I want to get to back to the patients again, and I want you to share a story about a patient whose life was significantly impacted by your innovative treatment approach for PAD. I have two that I'm going to share, but I'm going to let you go first.
Let me go about any of the patients that I've treated.
Any.
Okay, well, there's so many to choose from, but I
I
think
know, right?
impact is greatest when they've been told more times than others that they have no choice and nothing can be done. And I think the extent to which that has been told to them and the downward spiral that the patient has taken because of that is um, very impactful both to the patient and the patient's family. And then if for some reason you're able to reverse that trajectory, you make the biggest impact in that patient's life. So the one that comes to mind for me, maybe on the top of the list, and maybe one of the stories you were about to tell, but is came from you because uh, gave my name as an option for this patient, but this patient was to the point where they were told they had no options after multiple interventions and was told that they need an amputation, and then to the point was transferred to hospice for end of life care, saying that this was the end of the road for this patient. And thankfully, they had a contact and they were able to get to you and provide information that's so valuable to patients where they may or may not know what their options are. All their options are coming from one perspective, from one or two operators at best, but not necessarily getting a universal view of the patient's status. And so we were able to bring that patient in, and what was told was impossible was completely revascularized. It was a long, difficult procedure, but we revascularized that patient's leg, and I'm happy to say that the patient has not had an amputation, lost a couple of toes, is not on hospice. And this is, a couple of years later, and I still see this patient in follow-up. So that impact is what I'm most proud of when you're able to completely reverse the trajectory that this patient was on with a life-saving intervention.
Yeah. And I have another one where we had another um a surgeon from another state that ended up calling me and saying, "Hey, you know what I'm talking about? Do you know of another doctor, another surgeon in this particular area in Pittsburgh? It's a very high level person that is asking me for help, and it's their family member or their friend. Can you give me the name of a surgeon?" And I said, well, I don't have the name of a surgeon in this particular case. In this particular case, with how this person is presenting, I would actually go a different direction and I would go with Dr. John George, interventional cardiologist. And this person said, what? Are you sure? And I said, do you trust me? And I went ahead and put you in touch. And there you had it. This person had multiple, like I think even to the point of a Hail Mary bypass, had the axillary bypass and was like, there's nothing else we could do. And you went in and I think you even restored blood flow in some of the native vessels, bypassed the bypasses, and you were able to open up these arteries. And so, I mean, that was huge that you were able to do this. And I'm sure I'm curious what was going through your mind, when this patient came to you and I mean, were you thinking, I'm not sure about this one, but let's give it a try? And I always say, at least you're willing to try, right?
Absolutely. You can't guarantee results, but you can definitely give it a shot. And the reality is, if you have the expertise and you care about the patient's well-being, it can't be the end of the road without giving it a shot. And so you have to give it a try and a healthy try. And so a lot of times, some of those cases are long cases. They're challenging cases. They require a lot of equipment, a lot of time, a lot of effort. But if it prevents an amputation, that's a huge success, both for yourself and for the patient. And so you can't abandon that option. And that's unfortunately the reality of healthcare in this country is that an amputation is a quick procedure that is reimbursed very well for the amount of time that it takes to do it. And so sometimes the easier path is an amputation. And it's unfortunate that it doesn't go into the amount of work to revascularize doesn't go into the calculation in really figuring out what's best for the patient. And so you have to put the patient first and really do your best to try to revascularize.
Yeah, and it's people don't realize I've watched my fair share of amputations, and it's eerily, I mean, it's just scary. I mean, how simple it is. It's eerily simple. And I use that, it's not as simple, but when you're comparing it to sometimes the hours where someone's trying to eat their way through rock hard calcium to just create a little channel, and then they just cut off the limb just like that. I mean, the time that is really spent in that OR is sewing it up,
Yeah.
and making sure the flap is right. But that the cutting it off is just it's quick, and it's really, really sad how quick it is and how quickly, because of that, some doctors just jump right to it. And they won't give up the patient to a doctor who is willing to put their life on the line to save the limb of someone else, because it does take a lot of time underneath the radiation, for you guys to really go in there and open some of these complex lesions in the vessels. And you, on the other hand, are actually quick to give up the patient and quick to refer if you do see an opportunity. One case in particular, it was by happenstance that you ended up calling me and saying, "Hey, Kim, do you know a doctor down there in Southern California in Palm Springs?" It was a Friday afternoon, I believe, where very few options are available on a Friday afternoon, and particularly in Palm Springs. And you said, "I had this patient, and this patient's daughter came and didn't realize that this patient was a CLTI patient. This patient was in advanced stage with a wound that was infected, and she put her on a plane to take her back to take care of her out there, canceled your procedure, not realizing that, hey, why don't we just open up the arteries first, get your mom stable, and then take her?" So then she's calling you. I think this is how it goes, saying, "Now what do I do?" Well, you kind of left my state and you're asking me now what? So you called me and we were able to at least get the patient, because you took the time to get on the phone, even for a patient that couldn't see you. You didn't just say, "Well, you know what? You're screwed. You left me. I could have done something. Can't anymore." You took that next step and said, "How can I help you?" And you called the Global P.A.D. Association. You called me and you said, "Can you do something for this patient?" And we were able to, because of you, because you made that connection. You took that time. We were able to get the patient, one, to the emergency room, and I was in the daughter's ear the entire time. Repeat after me. This is what you need to say. And we were able to just get her enough antibiotics to get her through the holiday weekend. It was a holiday weekend. and I called up a doctor that was there in Southern California in this one area. And the insurance, this was even worse. The insurance hadn't even kicked in, doctor. And somehow I was able to score a this doctor who, out of the goodness of his heart, was like, you know what, we'll worry about insurance later. Let's save the patient's leg today. And I think you even coordinated or may have gotten on the phone with this doctor. I can't remember. But I mean, thanks to you. I mean, that's amazing to me. And that was one of the reasons. That was one of the reasons, many reasons, why you definitely are deserving of the U.S. Interventional Cardiologist of the Year. I mean, you remember that case well. I
I
can
do.
talk your praises all day long.
Thanks, Kim. I'm flattered, but in the end, it's unfortunate that this happens. I mean, when I saw the patient, I needed that patient in to get a procedure right away. I mean, I knew that she was in bad shape. But the reality is that life gets in the way sometimes. And this patient's parents were sorry, the patient was
The
here and
daughter.
the
Yeah.
daughter was in California, and the daughter had come to bring the patient in to see me. And then I scheduled this procedure the following week, and then she had no means to save her job by staying here, but she didn't feel like she could leave her parents here on their own. And so I mean, she is doing it out of the goodness of caring for them, but not recognizing the difficulty in trying
Yeah.
to find the appropriate care for that level of disease in a random location in California at the last minute. Which, you're singing my praises, but I just want to sing your praises because this couldn't happen without, doing what you do so effectively. And so I want to thank you for what you do for these patients, because in the end, having this network of high-end operators that are able to do this work even all over the country is how we're able to get the care even to the limited patients that seek care to getting what they need. And so if you're singing my praises for this one situation, but you've done this for so many patients. And that's in the end, that's what we need to grow. We need to be able to offer options for these patients that are
Yeah.
not getting these options.
And I always say I can't do it without the network. I'm just creating the web with people like you that are just incredible, that go above and beyond for patients. And you eat, sleep, breathe limb salvage. And I wasn't kidding, for those who are watching, that all of you, what we call CLI fighters, are truly putting your life on the line every day to save a limb or two limbs or three limbs. I mean, it's incredible. And you're not just saving limbs, you're also saving lives as well. I'm curious though, because you can do, legs and you can also do heart, but, um, there's a lot that you can do on your own, but, a multidisciplinary approach when it comes to PAD is critical. Can you talk about a patient in which multidisciplinary care and a team effort was really the reason why a patient ended up doing so well and still has their limbs in their life today?
Yeah, you want to be able, in the end, it's not about you fixing the patient, but really revascularizing and improving the quality of life for the patient as a whole. So this involves, like we said, medications and even non-interventional therapy.
Yeah.
It involves supportive care with supervised exercise, which you do great with the walking program and being able to literally walk beside the patient to improve their vascularization and even the flow into the distal extremities. It involves wound care, so working with podiatry and wound care centers to be able to offer the best services there. Sometimes it's advanced disease that requires skin grafting. Sometimes you need hyperbaric chambers. Sometimes you just need dressing changes. But these may be things that the patients don't have access to. So you can't just assume that you've improved the blood flow and the patient's going to get better. there's going to be areas where you need open surgery and bypass, and maybe that's the best option. If they have good veins that they can harvest and do bypass, and they're not high risk for surgery, and that is the best option for the patient, then that needs to be considered. So you need to be working with vascular surgeons, and since I'm not a vascular surgeon, I have vascular surgeons that I work with to be able to do some of those open procedures when you need to. Um, and then the follow-up, it doesn't end because these patients, like we have reiterated over and over again, need long-term care.
Yeah.
And so this involves, staying on top of their therapies, making sure that they're compliant with their medications, making sure that they have refills on their medications, and all of those things to make sure that they don't keep coming back for recurrent
Yeah.
procedures. And so without an approach that involves all of these spaces, and that might include their primary care doctor, their nephrologists or dialysis doctors if they're on dialysis, their endocrinologists and diabetes doctors, their vascular surgeon or endovascular specialist that does the intervention, their wound care, their home care sometimes. And so it's a huge team of people that should be involved in taking care of the whole patient and not just their focused vascular issue.
So share a specific case that had you scratching your head about how in the world this patient was not diagnosed sooner and what would have happened differently for this patient if only they were diagnosed sooner. You may have even had a patient that had multiple other procedures that were performed. So they may have had back issues. They may have had gout. They may have had something else, but nothing they did to treat those ended up relieving their textbook P.A.D. symptoms. And if only they would have been diagnosed earlier. Can you share a case?
Yeah, so I'll tell you that the most common ones that we see, especially as a cardiologist, are the ones that have heart disease or have been screened for heart disease, but not screened for anything else. And so that's what's most concerning to me, because the reason why they're seeing a cardiologist is because they have had some symptom or some risk factors that prompted the evaluation by a cardiologist. And yet, the outcomes are not necessarily the same if they've just been screened for coronary disease, because even though these spaces intersect, uh, they may present first with peripheral arterial disease. And so we have these patients that go for bypass surgery, for example, and they will have an open procedure to bypass their heart, and they will have veins harvested from their legs to bypass the blockages in the arteries to the heart. And they always do a carotid screen because they have to go under anesthesia and prolonged anesthesia. And so they want to make sure they reduce the risk of stroke when they are having open bypass surgery procedures for the heart. But then you'll see all these patients that get screened everywhere but the legs. And so you'll see that they don't get screened for PAD. And now they've taken, harvested veins from the legs for a bypass in the heart, and they've recovered from their heart, and now they're going through cardiac rehab and they can't exercise because their
Yep.
legs hurt. And then you find out they have advanced peripheral vascular disease, and now they don't have veins in their legs to bypass, which thankfully we can do a lot of these endovascularly, but they sometimes present much later because they think they've seen a cardiovascular doctor and they've been treated for their disease state, but their lower legs have not been assessed or evaluated. And so those are the patients that we see most often that are really ignored for their legs and for their peripheral arterial disease. And then they come in with non-healing vein harvest sites on their legs because they've done these endovascular harvests, but the skin doesn't heal on the legs. Their heart is completely healed because it's been bypassed, but the legs don't heal from taking the veins out of their legs because they have no perfusion of their legs. And so those are the most common ones that we see, and we see it quite frequently, unfortunately.
And 3 in 5 people who suffer a heart attack have PAD. So if only a doctor would have taken the time to feel their leg pulses, actually life and limb would be saved. And maybe you would never have a problem with the heart if their legs were checked. You fix the legs, get them walking, and maybe it would help their heart. So that's really important. I'm glad you brought up that point. Share a case with a big lesson for you and others. Describe the patient, describe the frustration with the case, and the actual lesson that you learned during this particular case. It could be a success, it could be a failure, doesn't matter, and what others can actually learn from that specific case. It could even include a little ingenuity on your part.
Yeah, I mean, I think we all learn from the procedures that we do. So even with the advanced cases that we do, there's something that we're constantly learning. And I'll tell you that even to this day, I'm honored to be getting this award, but there are cases that stump us, and we will call our colleagues, our peers, our friends to run cases by them, and get ideas, because there are no answers in some cases. There's no right answer in some cases, but there's just not a lot of options. And so these are limited avenue areas where you have to come up with unique, state of the art options to try to revascularize. And some of the things that come to mind are, even the idea of limb flow, or DVA, deep vein arterialization, is a technique to, when you don't have any distal end flow arterially to the tips of the toes, you're basically arterializing a vein in the leg that's already there, to allow perfusion of that extremity. It's a last resort, but it allows you to bring blood to a territory where you don't have options otherwise. And so, it's not a technique that I came up with, but just those kinds of thinking outside the box by pioneers within the space is what keeps moving the needle forward in having options for patients to really find a way when there seems to be no way. And so I think that's what comes to mind. And so I can think of patients like that, where I've tried and failed to try to revascularize arteries because there's nothing there to revascularize into. And then, down the road after 3 attempts, switched to arterializing the vein. And that's become and I'm talking about several years back, but now that's become a mainstream avenue for revascularization in patients where they have no options. And it's become a commercial product that we can use in those patients for deep vein arterialization.
And one more major question, and then hopefully maybe if a few people in the audience have a couple questions before you run off. But this one's a deep one. This one's going to have you thinking. I want you to share 6 minutes that mattered in your career. It has to be a defining moment, a catalyst for change, a spark that led you in a specific direction. It could be a conversation that you had with someone, a scene in a movie or a show or a documentary you watched, or something that was eye-opening that you witnessed. What would be your 6 minutes that mattered?
Okay, so I'm going way back when I was in medical school. And so this may not be the kind of story you were expecting, but I was going down a completely different path of becoming a pediatric cardiologist. That's what I thought I was going to be. I was fascinated by the heart. I loved kids. And so I thought, the natural progression would be to specialize in pediatric cardiology. So to the point where I did research in pediatric cardiology, published a couple papers, um, and then I had a mentor who I did research with within pediatric cardiology at the Children's Hospital in Cincinnati, and he took the time to sit down with me one day, and he asked me pointedly, "Why do you want to go into pediatric cardiology? Is it because of the pediatrics or is it because of the cardiology?" And I had to really think about that. At that point, it was just, it was just a routine, decision that I'd made because I liked both. But then when he asked me that to choose between the two, I had to really think. And I said, you know what? In the end, it's the cardiology that attracts me, and into the space, not the pediatrics. And he said, you need to do adult cardiovascular medicine. And I was like, why? And he said, there's so much more need, and there's so much more impact that you can have in a lot more number of patients' lives. There's a limited number of kids that need cardiologists because of congenital heart disease. But the rest of them are all adults with progressive heart disease, and we haven't found a cure. So if it is the cardiology that excites you, you should go into the adult space. And that completely turned my life around. I took his advice and started pursuing uh, cardiology, so in the adult space. And I can't imagine where I would have been if I hadn't taken that advice. And I'm so happy I did because I love what I do. I'm very passionate about what I do and truly the impact that we have. Not to say that pediatric cardiologists don't have impact in patients' lives, but I really love dealing with the adult patients that I have and the impact that I have in their lives, both from the peripheral vascular side and from the coronary side.
And all the patients that we have together absolutely adore you and are very thankful that you chose the direction that you did. But we actually do have a kid in there with Nancy who wants to ask you a question. So that's really ironic that you would bring that up right now because I think right now she's wishing that you did pediatric. Nancy, introduce us to Olivia.
First of all, congratulations, doctor. And
Thank you.
my granddaughter, Olivia. And
Hi.
she's worried about me. In fact, and I wanted to bring this up first. I just found out that I've enrolled into the Eli Lilly clinical trial. I get my first dose next week.
LP little
Because
a.
I have high lipoprotein A. I don't
Hmm.
know if I'm going to get a placebo or the actual drug. And I was just wondering your thoughts on that. Um,
Yeah.
and it's added to my worries a little or quite a lot, because I have gone on a 25-year journey of diabetes, coronary artery disease, heart attack, or widowmaker, then a heart attack afterwards, defibrillator, two stents there, carotid artery, peripheral artery disease, stent in my left leg. I'm
Mhm.
fighting with everything I have. All right. And so I wanted that's part of my question. And then Olivia has a question because she's worried about me.
And she's also worried about her future, probably too.
Because this could be genetic. So
Oh, yeah, definitely. What are like the symptoms of like how do I no, not like the heart attack, but like the leg thing.
she's concerned about my legs. And
Okay.
Okay.
Yeah. So
I said it.
yeah, so let me tackle both questions. So from your standpoint, Nancy, I think you're a perfect example of where all those vascular spaces intersect. Unfortunately for you,
yeah.
but the reality is it's the same disease state. It's in different areas of the body. It's just deposition of plaque inside your carotid arteries, inside your coronary arteries, inside your peripheral arteries that cause all of these different problems.
Mhm.
And it was probably caught in adulthood. And at that point, interventions were made to try to reverse that in each of those areas with interventions. But it's also a combination of getting the right pharmacology. The problem is you're fighting age, you're fighting family history and genetics. And, I always tell patients there are a few things you can change and the others that you can't. You can affect your lifestyle, you can affect your compliance with your medications that your doctors tell you to take. You can modify your risk factors. You can stop smoking. You can watch what you eat and exercise, but you cannot change your age and you cannot change your genetics. So those are two things that will impact you regardless of where you are. And so, whatever you can do in the spaces where you can make a change is what you need to do. And so you've done the right things in getting the revascularization piece done, but whatever you can do pharmacologically to limit your risk for advanced atherosclerotic disease is what you should do. So, LP little a is a lipoprotein A that is considered higher risk for atherosclerotic disease. And so if you can lower that, and it remains to be proven, that's why this is in studies right now. We know that it's correlated with atherosclerotic disease, but whether you can impact the progression of disease by limiting it, lowering it is remains to be seen. And so that's what's being evaluated in these trials. Not only are you, by participating in this trial, helping yourself by lowering that risk for yourself, you're also advancing the science by helping us learn what impact it has on patients like you that have advanced disease. So thank you for doing that, but also, I think it's the right thing to do for yourself to try to limit as best your risk factors for progressive disease.
Well, thank you. And I'm doing it for my grandchildren, and I already have two of my grandchildren have been tested for cholesterol, and they both have high LDL. They are 13 and 16 athletes, and it's scary for them. So I'm doing that for them. I'm doing it for me. I'm 71. I've been through a lot, and I have a defibrillator too. So, and I actually had my heart stopped, and I was out line dancing, and there was an EMT there who saved my life.
Wow.
And I've been through a lot.
Yep.
I'm fighting really hard. I walk an hour a day. I'm eating healthy. I quit smoking over 20 years ago. I'm doing everything I can.
That's fantastic.
Yeah.
So what would be your best advice for Olivia?
Yeah, so for Olivia, I know you asked about symptoms, but you shouldn't be even concerned about symptoms because symptoms don't come till much later. For you, it's more about prevention. So knowing that this is your family history, doing the best that you can with, watching what you eat, exercising, not getting into high risk lifestyles like smoking, heavily oily, fatty foods, sedentary lifestyles. We don't want to get into that track because that increases your risk as you grow. And the reality is for your grandmom, she probably never knew, but she was probably born with familial hyperlipidemia, with high LDL levels, and even at a young age, which she probably didn't know about till she had advanced disease. But in your case, you have the opportunity to mitigate that early. And so even following with your doctors, getting blood tests to check your lipid levels and interfering with that progression before it gets to that advanced state would be the key for you.
So
and it's great.
She should be tested also at a young age for cholesterol, right? Like right now.
If it is familial, so there's different types of hyperlipidemia. So if you have familial hypercholesterolemia, yes, she should be tested.
Okay, that's good to know. And is there any other tests that I should get for my heart since I have had a heart attack? Because I used to get stress tests every year, and now they don't do that unless I have symptoms, my cardiologist. And I go to electrophysiologist, cardiologist because I have the defibrillator. And I'm just wondering, when I go to see him, in the next few months, should I telling him about this new, diagnosis now that I have, of the lipoprotein A. Is there any other tests for cardiology that I should get? I mean,
No,
What
I
about a
don't think
PET scan?
CAT
I
scan
just had a doctor talk about a PET scan.
or PET scan. Yeah, so a PET CT is basically a newer version of a stress test to look to see if there is flow perfusion abnormalities in the heart.
okay.
Typically the indication for insurance approval is symptoms, and that's the reason
Mhm.
why the doctor said, that you need symptoms before we'll do any testing. But here's the problem. I'll tell you that as people get older, you tend to reduce your exercise level because you look at that as a natural aging process.
Mhm.
And so if I'm not saying that's the case for you, but the reality is a lot of people say they don't have symptoms, but really what they've done is stopped exerting themselves.
Mhm.
So you need to clearly define that. And so the question is, you're not going to have symptoms if you're just sitting around. We're not expecting you to have symptoms. We
Mhm.
expect symptoms when you push yourself, where your heart rate goes up and your demand for blood flow into your heart goes up. That's what a true exertional activity is. And if you're not doing that at baseline, then you don't know if you have symptoms. And the way you know you have symptoms is if you get on a treadmill and see if you can manage what you were able to manage before. And so, there's a fine line there of not having symptoms versus not exercising enough to trigger symptoms. And that's what your cardiologist needs to
I'm
do
gonna
and
talk
what
to him.
you need to be aware of.
Yeah, I'm
Such
gonna talk.
a great point. That is, Dr. Parag Doshi out of Chicago mentioned something like that just recently, and he said it's not about asking them, well, do you have angina? He says fatigue is the new angina, but he said if I ask the right question, I get the right answer, and I ask them, what were you doing 2 years ago today that you're not doing today because you think that you have aged? And so he kind of starts on that track to get to the bottom of, wait a minute, they're slowing down because maybe at that point 2 years ago, they might have had a little angina, they might have had something. And so now they've kind of gotten used to doing much less and much less and much less. So it's about those right questions and really keeping an eye on, what would you be doing if you
Mhm.
weren't more fatigued? I just have a couple more questions, if you don't mind, Doctor,
Yep.
coming in. Um, I don't know if Marie wants to jump in and ask her question live or which one she wants me
No,
to.
you.
You want me to ask that? Okay. So she has P.A.D in all of her limbs, arms and legs. She's experienced 3 times now where her arms get a very odd feeling at the bicep area, and it makes her feel like she can't move, almost weighted or tied down. Does that sound P.A.D related? She has severe CLTI in her legs.
Yeah, so I mean, in isolation from just reading this and knowing your history, it can be PAD related. So, subclavian artery stenosis or insufficiency of blood flow into the arm can cause that heaviness in the arm, just like walking can cause heaviness in the leg. One of the ways to test for it is to try to raise your arm above your head and flex your fingers back and forth and see if it makes you lightheaded or dizzy. Or when you are doing things against gravity, so pushing up with your arm, if it gets extremely fatigued. Those are indications that you're not getting enough blood flow to the arm. And so those can simulate those symptoms that you're describing. But there are many things that can cause those symptoms. So I don't want to say that it's definitely PAD related, but knowing your history, it is something to consider.
And Kim has a question. Kim, do you want to unmute and ask Dr. John George your question?
Hello. Yeah, I was just wondering if you've got PAD and CAD, is there a time frame where you should, get regular CT exams, or do you just regular get the CT exams if you have change of symptoms or something?
Yeah, so there is no indication to get regular CT scans. That's just a lot of radiation and contrast, unless there's a reason to do it. There are many different reasons to do it, but just having the history is not a reason. So what I would say is that CT scans are typically a diagnostic modality. So you do it to determine if a patient has PAD or determine if a patient has CAD. But once you have the diagnosis, if you've had an angiogram and it's been diagnosed, then it's following the level of disease, and by then you know where the disease is, and so you can do focus tests for those areas, and that could just be ABIs or ultrasounds that are less invasive and easier to do on a regular basis and repeatedly.
Thank
Fantastic.
you.
You mentioned about the medications and all that, and you take statins for not just for lowering LDL, but also it's a plaque control also, I guess. Reading online about the side effects of statins, it can cause neuropathy and things like that. How do you know if that is causing neuropathy? What is there a special test for that, or do they just stop it altogether and see what happens?
Yeah, so it's really not neuropathy, but it's myalgias, it's muscle aches that you get from statins, and so it's very hard to tell. Sometimes it's hard to tease out, and I've had plenty of patients where we do a trial where we stop the medication, and it's still persistent, and so we know it's not the drug, and it's really important to continue the drug at that point to limit the risk over the long term, rather than just flat out stopping the medication. So it does require teasing out some of these nuances, finding out exactly what the symptoms are. Is it truly related to the statin? There's all kinds of stuff that people report. But what we do know, the most common side effect is myalgias, and even that is less than 10%. So it's still a pretty low event rate in patients. And even if it is, sometimes people have it starting off on the statin, but it goes away. And so if it does go away, it's a good drug to be on because of all of its positives and benefits.
And Marcia is jumping into.
When you were talking about statins and some of the adverse side effects and that they can go away, what would you tell patients? It just seems like so many people say, I can't take statins. I just can't, I won't take them. And so, like, if it would go away, are the benefits versus some of the effects that they're having? Because it sounds like they're really good for us.
Yeah, so one of the ways that I work around that, honestly, I am on one myself, and so there's no better example for a patient when I tell them, I'm on the highest dose of the statin myself, and if I didn't believe it, I wouldn't take it. And so that usually clarifies the concern for risk or issues. But having said that, people report all kinds of side effects, and you just never know. There are listed side effects and there are non-listed side effects that people report. There's so many confounding variables, and it's very hard to tease out sometimes whether it's a medication or not. The only way you can prove it is by stopping the medication and seeing if that makes a difference. Because these are all reversible things. It's not any permanent damages that are done by these medications. So if it is not reversible, if that muscle ache doesn't go away when you stop that medicine, it's not coming from the medicine. So those are the questions that you have to ask.
Yeah, no, that was a good question, Marcia. Thank you so much. Dr. John George, you are the U.S. Interventional Cardiologist of the Year, and I'm sure anyone who's tuned in can definitely understand why. We appreciate everything that you do to save life and limb, exhausting all efforts, both physically as well as mentally, and, emotionally connecting with your patients. Thank you so much for all you do.
Thank you, Kim. Thank you again for all of you that joined in. It's an honor to be recognized for this. But thank you, Kim, for what you do and for P.A.D. and for patients all over the country.
Thank you so much.